Good morning. This is Makola. I'm a field educator out of Station 7, and I wanted to go over blood administration. I'm just going to do these kind of like LifeStar shorties, I'll call them, where they're just a brief presentation about information that may not be in the protocols that you can use out in the field. And the information here is just to clarify some confusion that you might have. So one of the things that we talked about during the last critical care training in December was blood administration. Not everybody was 100% sure on how you run blood products. One question was, can you run blood products with D5W, or what about lactated ringer? Can you run our blood products on the pump? So people just weren't 100% sure about everything. So that's what I want to clarify here. I think the whiteboard is a good tool, but maybe this would be a better platform. So let's give it a try. Let's give it a try and see what happens. So the reason you'd be running somebody on blood products might be because of anemia or low hemoglobin levels. The red blood cells might be an abnormal size, might be too big or too small, like with sickle cell, or they just are too few. Another reason you'd be running blood is for trauma, for patients that have reduced clotting factors, or they just need to replace volume. You might be running blood for that reason. And cancer patients oftentimes have blood running as well because their cells are damaged from the radiation that they receive in chemotherapy. So those are just a couple of the reasons why we'd be running blood products. So let's get into the body of the presentation. All right, so here are the 5 most common blood products that we would be running. The ones that we're likely to see in the back of an ambulance would be packed red blood cells or fresh frozen plasma. The other ones are fairly rare, and we don't really see them too often. Before you start transporting a patient that has blood product running, the nurse is probably going to give you the CBC, which is a complete blood count. The three numbers that we really care about are 5, 15, 45. So these numbers represent, number 1, the red blood cell count. This is usually given in trillions of cells per liter. That number is going to be 5. The next one is hemoglobin. That's going to be 15 grams per deciliter. And the last one is hematocrit, and that's going to be 45%. So 5, 15, 45. 5 is going to represent red blood cells, hemoglobin is 15, and hematocrit is 45. Hematocrit is just the ratio of red blood cells to total blood volume. So 45% of your blood should be red blood cells, and the other 55% is going to be plasma. So that's what the nurse is probably going to give you, and so just keep that in mind. So the first blood product is whole red. Whole red is pretty rare. You don't really see it that often. Its main purpose is for hemorrhagic shock or patients who are severely anemic. And it's really just intended to replace volume as well as the other components found in blood. So that would be like the clotting factors or white blood cells. The only thing that is added to whole blood is citric acid, and citric acid is an anticoagulant. It increases the shelf life of the blood product, and it prevents the blood from coagulating. So that's when you would see citric acid. Out of a 500 ml bag of blood, about 60 mLs is going to be citric acid. So and the citric acid does affect cardiac function, so that's something that we'll get into later. So the next one is the most common one, and that's packed red blood. Packed red it's really not intended to replace blood volume. Packed red is really just supposed to increase your hematocrit percentage or your hemoglobin. So this blood product is what it sounds like. It's just condensed red blood cells. This is usually ran with normal saline, and it also has citric acid, that anticoagulant that whole blood has in it. This is the most common one that we run. Fresh frozen plasma is another fairly common blood product, and fresh frozen plasma is just a blood product that does not have red blood cells in it. It does, however, have that anticoagulant, citric acid. Fresh frozen plasma is given for people who are like, they have a coagulation, like either coagulation factor deficiencies or they're just actively bleeding, and they need the anticoagulant inside the plasma to stop the bleeding. This is also given for patients who like maybe take too much warfarin, and they need to those clotting factors. All right, so the next one is cryo. Cryoprecipitate is given to hemophiliacs. This one is very rare. It's also extremely expensive. The bag that you're seeing there is about like 30 to 50 mL. So what's done is the clotting factors are extracted from the blood. So an example of that would be clotting factor 8 and 13. And then one I don't have on there is von Willebrand clotting factor. And there's also fibrogen. Think of these clotting factors as like the glue that binds the platelets together to clot a bleed. So hemophiliacs have platelets, but they don't have these clotting factors, which makes the platelets kind of clump together and bind together. So that glue is missing. So that's what cryoprecipitate basically is. And the last one, it would be just platelets. Platelets are given for one reason mainly, and that's just to replace somebody who has low platelet counts. And the name of that is thrombocytopenia. This is really the only purpose for platelets. There's really no other reason why you would be giving somebody platelets. So those are the 5 most common blood products that you would be giving someone. So I was curious about what the cost of blood is, and it turns out it's different for each type of blood product that you would have. The most expensive one would be platelets at $500 for a 35 ml bag, and whole red is going to be about $200 to $300. The reason that there's a range is because this is all dependent on availability. You can't make red blood cells in a lab, so you have to harvest and get it from donation. So that's why the price might vary, but this is kind of just like an average number that you would see. The average person has about 5 liters of blood, and that comes out to 10 of these 500 ml bags. So if you were to charge $300 per bag, all the blood in your body would be about $3,000. If you look at the bottom, there's a centrifuged bag of whole blood, and you can see how it's separated. At the very bottom, you're going to have your red blood cells because they're the heaviest, and then you're going to have your platelets, and then on top, you're probably going to have like your more liquid plasma, and like clotting factors going to be at the top. So that's just kind of a visual of how your blood is separated when they centrifuge. So let's briefly go over how you hang blood products and just some considerations for transport. Running blood is a paramedic level skill. You don't need to be a critical care paramedic to run blood. The only caveat is that if the physician, if the sending facility hands you a unit of blood, and they ask you to start the drip, it now becomes a critical care skill. So if you're given a unit of blood, you need to do a few things. Number one, you need to make sure that you are also given blood tubing. It's also called Y tubing, and there's a picture of it there. And you also need to make sure that you hang saline along with the blood. Y tubing has a filter in the drip chamber that keeps any blood that may have coagulated inside the bag from reaching the patient. So that's why you have to have this special blood tubing. So the way that you run a blood product, and this might be obvious to some people, but the first thing you need to do is you need to run saline through the line all the way to the very end. Make sure that the saline is actually above the filter. The reason for that is you don't want the blood to make contact with the filter. If that happens, the blood could coagulate. It's just another area for the blood to coagulate. So that's why you would want to have the saline above the filter. Once the saline has filled the entire drip chamber and has gone all the way through the line, then you'd want to start running the blood product. So clamp off the saline and then start running the blood product after that. You would want to start running the blood product fairly slow. I looked at the University of Maryland, Baltimore's recommendation for running blood, and they suggested like 30 to 50 mLs an hour at first. And the reason you do that is because you want to avoid a transfusion reaction, which is basically just an allergic reaction to having blood products being ran. And so when you give that blood slowly, you're not administering as much of a blood product that could be dangerous to the patient. So you're kind of seeing how they react to the blood product. So you want to run it slow. After about 15 minutes or so, you can set the drip rate to whatever you want. We do not run blood products on our pumps, and we don't run blood products on D5W. The reason is because for D5W, for example, D5W can cause hemolysis, which is a damaging of the red blood cells. Once red blood cells have been damaged, they'll have to get processed by the body, and that usually happens at the level of the kidneys.
if the kidneys are overwhelmed because so many red blood cells have been damaged, it can lead to rhabdomyolysis. So that's why we don't run blood with D5W. Also, our pumps will damage red blood cells, and that can also cause rhabdo. So make sure to only run blood products with saline. That's a very important detail. So once you've been running the blood, and let's say you've completed the unit, and now all you have left is saline, you want to close the roller clamp that's connected to the blood tubing, and then you want to flush the rest of the line out with saline, and you can just run the remainder of the saline if you want. So just keep that in mind. Also, if you need to give, like, let's say you only have one line and you have blood going through that line, if you need to give the patient a medication, you have to stop the blood transfusion. You'd want to flush the roller clamp below the drip chamber needs to be shut off. You need to flush the rest of the line out, and then you would administer the medication. Then you would flush it with saline, and then you can run the blood. So basically, never let the blood make contact with the medication that you're giving. So just another small detail to keep in mind. Make sure to take lots of vital signs too, and the reason is because there's always a chance of a transfusion reaction, which is basically just an allergic reaction to the blood product. This is very rare, and if you just hung the blood, it's not likely to happen within the amount of time that you have the patient. But here are just a few of the signs and symptoms that you might have from a transfusion reaction. Certain hospitals will actually, before they even give the blood product, they'll give the patient Benadryl and acetaminophen. And that's just kind of their way of preventing a transfusion reaction from happening or from the symptoms from getting severe. So that's not something we would recommend, but it's something to keep in mind that if you see a transfusion reaction, you stop the blood product immediately, you disconnect the line. You would want to then give Benadryl and treat the patient like they're having an allergic reaction. Because essentially that is what's happening. All right, so that's kind of like just the basic setup for blood drip, and make sure to check vital signs often. If you hung a drip, check their temperature. And if you really want to impress a nurse at the receiving facility, tell them the temperature before and maybe the 2 times that you took it during transport to prove that their temperature did not change. That's one of the more sensitive signs and symptoms to a transfusion reaction. So just keep that in mind.
So one last consideration when you're transporting a patient who's received a large amount of blood is to look for hypocalcemia. Try to have the patient on a 12 lead. It will help you identify hypocalcemia if the patient is suffering from it. So hypocalcemia is just a QT interval that is greater than 500 milliseconds. The QT interval is measured from the beginning of the Q wave and the end of the T wave. It's usually the danger zone, so to speak, is around 500 milliseconds. If you're over that, then that's kind of an indication that calcium chloride would need to be given. Usually, if somebody is receiving more than like 3 to 5 units of blood, depending on their size, their body mass, they'll get 500 milligrams of calcium chloride. So if you see this on the 12 lead and you suspect hypocalcemia, wouldn't be a bad idea to give calcium chloride. You may want to check with medical control. The leads that you'd usually want to identify hypocalcemia would either be in leads 2, V5, or V6. These are the ones that the University of Maryland Baltimore Critical Care Program recommends, and they're usually the easiest to spot. So another rule of thumb to keep in mind is the QT interval should really be less than half the R to R interval. If it's more, then that's a sign of hypocalcemia. The patient might also begin to complain of like muscle cramps and aches and pains. That would be another indication that you should put the patient on 12 lead. So yeah, that's basically it. Just make sure the patient's on a 12 lead. If you don't, Tyler Christofoli will hunt you down and kill you. And just have a great day, and thanks for listening.
Hello here, Tyrell Steins, critical care paramedic. I'm just going to jump in on Mikola's presentation and say LifeStar does not run blood on the pump, just reiterating that. I know there's been confusion in the past, and the risk versus benefits just don't outweigh. you have an increased risk of hemolysis, the increase in junctions and kinks, twists, the increase in friction when you start adding multiple tubings on together. It's one more thing that the blood has to run through, and everybody can do hand calculations, so we just don't need that risk there. Blood and blood products can be run by hand. You can do the math.